Case-based discussion session 1. In here, a 20-year-old rugby player presented with fever following a practice session. He has several bruises over the right thigh. His past medical history is unremarkable. On examination, he looks ill and blood pressure was low, that is 90 or 70. Pulse rate was pretty high, around 101 beats per minute, and respiratory rate was 32 per minute. He was admitted. 2 blood cultures were taken and empiric vancomycin, it is 15 milligram per kg or 12 level as 2-hour infusion was initiated. So what is the probable diagnosis? So it says 20-year-old rugby player and apparently well and presented with fever following practice session. So it implies kind of skin and soft tissue infection because patient has had several bruises over the right thigh. But apart from that, it says patient's hemodynamical status was unstable. So it implies a systemic infection, more towards a bacteremia. Bacteremia more often following MRSA, methicillin resistant Staphylococcus aureus, most probable. So etiology is MRSA. So what is pathophysiology? Following bruises, usually this pathogen MRSA could be a part of our nasal, perhaps it could be a colonizer in our nares or axilla or in the perineum, in skin. So when there are bruises like contact spot, there may be possibility of getting bruises as well as some lacerations. So as a result, this colonizer may reach into our deep tissues, perhaps subcutaneous area. Ultimately, it may lead to bacteremia because it has cell wall properties like gram glycolic acid, lipopolysaccharides, specifically glycolic acid. Then there are like pantene, valentine, glucoside like PVL toxin produced. Then there are a lot of enzymes which are capable of destroying subcutaneous tissues and fascia like hyaluronidases, elastases, a lot of collagenizers, and there are pyrogenic exotoxins. So all together, including PVL, which can later on, once it reaches to the blood, it may lead to further bacteremia. So that's the case. So virulence mechanisms as such. So on the next day, microbiology team informed that both cultures were positive for Staphylococcus aureus and next day found to have MRSA with vancomycin susceptibility. So it is here, it is in the Chromega. Chromega, which we use to, it's a selective differential media. So once particular specific isolate is there, there is a colorimetric or color change by following enzymatic reaction. So it may seen as observed as a color change here. So MRSA is a Chromega. How do you confirm it is as MRSA? So for that, once we have found gram, here it's calorimetric or MRSA Chromega, but still we want to do coagulation catalase test, which should be positive, then coagulation test as tube goes light coagulase test, which will confirm Staph aureus, and more specifically, we would cefoxidim test on Muller and Nega following application of this MRSA isolate microbial load. Then following incubation at 35 plus or minus 2 centigrades. On the next day, we can see is there a zone. If zone is less than 22 millimeter diameter, it would imply that according to CLSI, it is MRSA. If it is higher, more equal to 22 millimeter in diameter, it is methicillin susceptible Staphylococcus aureus. How would you manage this patient? Here, the physician has wisely initiated the best empiric therapy, suspecting the possibility of MRSA. So it is vancomycin. So now we can continue vancomycin. Meanwhile, we have to have a serum creatinine baseline value and also CRP, as well as it is better to have a ESR. This patient may require minimum 14 days of antimicrobial therapy while monitoring the serum creatinine and every other day of CRP. No need to do it from day 1 or day 0, day 2, day 4 likewise. So once we are having CRP at baseline, and if we would repeat in 48 hours following initiation of anti-MRSA antibiotics, if there are response, maybe partial response, so then we can do likewise in not in another 3 days, 5 days likewise. Meanwhile, we have to exclude possibility of infective endocarditis. For that, we have to do a two-dimensional echocardiography. Then we have to do eye referral to exclude endophthalmitis, as well as we have to do ultrasound scan abdomen to exclude the possibility of deep-seated organ cryptic abscesses, because that could be the source. But in this case, there's a straight history about this young chap. It's a rugby player and has had several bruises, so it implies that that is the probable source. So those common infections are mainly, it could be infective endocarditis, endophthalmitis, as well as it can be leads to septic carditis, osteomyelitis. Likewise, there are a lot of infections. So how would we monitor the response to the therapy? So at the same time, since this MRSA, following initiation of the anti-MRSA antibiotics, that is vancomycin, we have to do at 72 hours at day 3, do another single blood culture to, it is termed as clearance culture, to exclude or to assess the response to the therapy. If cleared, that is a good response. Prognosis is good. If it is not clear, that implies still bacterium is persisting there, maybe focus also there, maybe. So we have to exclude the possibility of cellulitis as well as subcutaneous or muscular abscesses. So as local complications, they may develop, and continuously it may lead to bacteria. So then CRP and procalcitonin would be a good option if we do. So that is the thing. Then procalcitonin we can do daily, but it's a costly test and less available, but it's suggestive of bacterial sepsis. So ESR we have to do weekly. So combining those inflammatory markers as well as clinical response, while about the clinical status, all collectively would be helpful to assess the clinical response. So targeted therapy in here, this case, empiric therapy as well as targeted therapy would be same, because it is MRSA and often it is vancomycin susceptible. We have to do vancomycin susceptibility. So similarly, in this case, we can continue it. So about the MRSA clinical or infection control is another aspect. Hand hygiene is very much important, as well as fine movement of hand hygiene and incorporation of alcohol antiseptics are helpful. And if patient not in this case, but if usually we have to do critical audits about hand hygiene as well as MRSA screening, colonization screening, because as I said earlier, it could be in our anterior areas, axilla or perineum or skin. So we have to do skin screening test. And if it is positive, not all the cases, specifically when the patient is awaiting to undergo prosthetic joint implant, as artificial joint implant, hip, knee, maybe any elbow, or awaiting for coronary artery bypass grafting, CABG. So usually bypass. So we do those screening. Then if screening is positive, we are going for MRSA decolonization using mupirocin nasal topical application plus coexidine bath except phase. We ask them to bath, apply it prior to application. We just ask them to apply over the earlobe to exclude and keep some time, maybe in 20 minutes, and check whether is there any hypersensitivity or allergy. If it is not, we ask them to have daily bath for consecutively 5 days plus mupirocin 3 times per daily applied over the anterior nares, both sides, and have their both bed linens and regular clothes should be in boiled and wash in hot water and allow them to dry. And after once this decolonizer regime is completed at day 5, we just ask them to appear to the clinic in 3 days later. Then we do repeat MRSA screening test. If it is negative, that's fine. If it is positive, then depending on the emergency status of the patient, we may do the appropriate manner. But sometimes we may give prophylactically just prior to surgery. We have to give vancomycin instead of cefuroxime and metronidazole. So shall we move to the other case? So this is case number 2. A 30-year-old male farmer presented with fever and right below knee swelling. You can see redness and tenderness for 1 day. It's an acute history. His past medical history is normal, uneventful. On examination, he looks ill and his blood pressure was again low and pulse rate was high. So it implies patient is hemodynamically unstable. Usually it should be less than 100, usually around 80s, maybe 70s. Blood pressure usually depends on the age, but it's a young fellow, so it could be around 130, 90, but it's here, it is impending shock, it implies. He was admitted, definitely sent to the high dependency units or maybe intensive care units, and 2 blood cultures were obtained at emergency department, and empirically piperacillin tazobactam and clindamycin was initiated. So fluid was given as crystalloids and parenterally, and they use modified early warning score to assess the uh, status of sepsis. And when mousse is applied, we have to do at least 30 minutes in or half an hour to assess the progress of the sepsis. Mousse score, straight away it gives a score, and it assesses several parameters including blood pressure, heart rate, then oxygen saturation, then temperature, likewise. Then we go with the our half an hour we have to assess patient is deteriorating, no improving, no status, no any change. On admission, we have done a C-reactive protein. It was high, around 230 milligram per deciliter, while procalcitonin was fairly high. It is 120 nanogram per liter. So give 3 differential diagnoses. In this case, it is a skin and soft tissue infection. Most top of the list is necrotizing fasciitis, but it could be cellulitis or erysipelas. If margins are there, visible margins, so it could be more often erysipelas. But this case, it is redness, swelling, blisters, and all over there, and sub hyperacute history, acute history implies it could be top of the list is necrotizing fasciitis. So compartment syndrome. So they have done surgical referral and fasciatal. They have cut these areas to remove the pressure within these facial compartments. Or else if it is not removed due to this accumulation of fluid, air, maybe other uh, materials leads to increase the pressure of the vasculation, ultimately terminal or distal limb maybe leads to gangrene and necrosis. So avoid that. to prevent that, they have released those compartments and by fasciotomy. So at the same time, while doing fasciotomy, they have taken multiple tissue samples and sent for histology and microbiology. So how we send for the histology? Histology, our main objective is to obtain the histopathology report. For that, we put them in formalin or formal saline. While in the microbiology, our main aspect is to assess the etiology. Or we have to keep the viability of the microbes who lives within these tissues, and later we can assess their growth and identify, isolate them, and go with the antimicrobial susceptibility testing. For that, we have to give them sterile normal saline. If we put contaminated saline, so we may find a different pathogen, maybe wrong one, and we are going to treat to the different or wrong organism. Ultimately leads to the failure of the therapy. So we have to put sterile. At the same time, normal saline is a good media because uh, it will not harm the pathogen. Like if we put formalin, it will kill the pathogen, but it's good for the pathological microbiology. We have to keep the viability of the pathogen. For the next day, microbiology team informed his blood cultures are positive. We have taken two and suggestive of streptococcus species. Give one characteristic feature on blood data, that is, it could be beta hemolytic. It's a complete hemolysis due to their enzymes, and gram staining of isolates, that is, gram positive cocci chains. Antimicrobial susceptibility test profile came as it's susceptible to penicillin, clindamycin, and piperacillin tazobactam. Further, his tissue specimen culture findings are also compatible with blood culture, that is, they have isolated streptococcus pyogenes. So how do we streamline the antimicrobial therapy? Give the rationale. Perhaps in the first case, we have initiated piperacillin tazobactam as empiric therapy, while giving the clindamycin, both including penicillin, all three antimicrobials. Penicillin also susceptible. Perhaps we can streamline, we can, depending on the patient's situation, but we can de-escalate. Perhaps we can go with the narrow spectrum penicillin because isolate is susceptible to penicillin. Other thing is streptococcus pyogenes. Universally, they are penicillin susceptible. Luckily, streptococcus species except pneumonia viridis like pyogenes and A-galacti are still penicillin susceptible. And we are giving clindamycin. So we have to continue clindamycin. It's a protein synthesis inhibitor. So those streptococcus pyogenes, they produce multiple proteins, protein toxins. So if we give protein synthesis inhibitor, it will reduce the toxin production of this pathogen, because this pathogen, multiple organisms are growing around here. We are term flesh-eating bacteria. So there are multiple bacteria. They are within these tissue compartments, different tissues, and also they are in a lot of, like the Staphylococcus aureus. He also the elastase, esterases, collagenases, hyaluronidase. So those enzymes are destroying these uh, tissues, including fascia. So we have to prevent that. Further, at least we give antibiotic penicillin, which is targeted therapy, while clindamycin, it's added and synergistically, I mean, giving a help to reduce the protein synthesis, and penicillin will act on the cell wall and inhibit their replication and growth. So what is the desirable duration of therapy? It would be like maybe 14 days, even more. How do you monitor the response here? Clinical response, as well as we can do CRP in 48 hourly while progesterone in daily. But in the first case, once we have initiated the antibiotic, we have to do in 48 hourly or next day PCT because patient is in a gravely condition. Then we can later do at least 2 or 3 days later with the response. Clinical response will be informed, including the patient status, clinical examination finding, as well as patient's usual appetite, how patient looks, everything gaining patient all oral conditions. So we'll move to the third case. So it is a 20-year-old male presented with fever, headache for 3 days. He has a rash. It starts as pink reddish pinprick-sized lesions, progressing to larger purple bruises like markings as the rash spread and further bleeding occurs. So that's how it goes. Over the past 2 days, it's acute. He recently traveled to Mecca pilgrimage. His past medical history was uneventful. On examination, he looks ill and blood pressure was again low and pulse rate was high. What is the probable diagnosis? Patient present with fever and headache. So it more towards central nervous system, specifically involvement of meninges. So most probable etiology, it is patient has recently traveled to Mecca, so in the sub-Saharan area. So meningococcal meningitis or Neisseria meningitis is the commonest etiology, and this age is also vulnerable or more common. How could you confirm the diagnosis? For that, we have to have blood cultures. So blood cultures will be helpful and it takes time, but depending on the bacterial load, it will grow well. At the same time, we can do the cerebrospinal fluid analysis, including for the cells, proteins, sugar, then for the culture, and as well as for molecular diagnostics. Has what is this is sorry for again. What is the test given in image B? It is glass test. We'll say glass pressure test or glass test. So it implies if there's once we are pressurizing with using the glass over these rash or lesions, if it is not fading away, it implies that patient is having a meningococcal septicemia. So usually pathophysiology is usually this pathogen reside in our nose as colonizers. Usual Neisseria meningitis as a colonizer. So maybe due to patients lowering of immunity, maybe even the pathogens virulence, this may reach to our central nervous system in different ways. One way is it can go along the olfactory nerve buds and retrograde axonal pathway, or else it can may invade into the blood vessels and go, or that's how mainly they reach them. Or maybe from anterior nearest to surrounding blood vessels and tissues and later on reach into the central nervous system. That's the third way. So once they are producing this gram-negative bacteria, they are in gram-negative cell wall properties, lipopolysaccharides, peptidoglycans, those things. So they may act as endotoxins. They are capable of producing different toxins. So they may lead to invading and favoration all the meninges. And once they reach to the meninges, they utilize those cerebrospinal fluid nutritions and leads to uh, replication within there, and they are due to virulent factors. Body may identify them as a foreign material, and there may be immune reactions, complement activation, ultimately leads to cytokine productions, pro-inflammatory cytokines, those things, and leads to inflammation. So it manifests as inflammation and infection in the meninges term as meningitis. So etiology is meningococcal meningitis, and this pathogen is capable of developing uh, bacteriemia and septicemia. So as a result, these organisms may reside and their byproducts and cytokines produced by body may lead to vascular dilation, endothelial um, inflammation, and manifest as rash. And also there is a possibility of adrenal failure as well. Best empiric therapy for this condition is ceftriaxone, often this pathogen pathogen is susceptible for ceftriaxone, usually we give anti-meningitic dose, so double dose, weight-based dosing. If it is usual dose, not weight-based, that is 2 gram per 12 level, or else we have to give 200 milligram, 100 milligram likewise. How to prevent this condition? So this we are having the vaccine ACW125. So Neisseria meningitis, they are ready for ABC W135. So we are able to cover most of the pathogens by this vaccination. So we have to have 2 vaccines, and also general hand hygiene and general measures should be sanitary measures we have to maintain.